Hi, everyone.
Okay. Hi, everyone. This is Veronica Seneriz. I'm the founder of Lymphie Strong, and I want to welcome you to our live Q&A with CYNTHIA SHECHTER of ShechterCare in New Jersey. Also along with me is my co-host, Pernilla Henriksen, who's joining us from Italy. She is the moderator of Lymphie Strong. Before we get started, I do have to remind you that we are being recorded at this time. And just a quick disclaimer that the ideas, suggestions, recommendations, and content of the webinar are intended to be for informational and educational purposes only. No medical advice is being rendered. There's no express guarantee of completeness or accuracy. While the speaker is a medical professional, this does not substitute your relationship with your own medical professional. And so the opinions expressed are not designed to treat any disease, condition, illness, or injury. Before beginning any changes or modifications, be sure and consult your own private healthcare physician, CLT, or anyone you have that relationship with. Okay, so without further ado, I'm introducing CYNTHIA SHECHTER. Welcome.
Thank you. I'm really excited to be here. I actually wanted to do this for a really long time, so it's awesome to finally be part of Lymphie Strong. The reason that I wanted to do it is because I like to help people figure out how to manage without feeling like that's all that you do. So I do specialize in upper extremity and breast cancer related lymphedema. I do treat lower extremity swelling and lymphedema. However, my caseload is closer to 90% breast cancer, 10% lower extremity. So that's just because that's who calls. Honestly, I will treat anyone. I just want to help people. So how can you get the answers about your lymphedema and your lymphedema therapy without sounding like you're unappreciative to your clinician? It's a tough one. I think what's most important is that clinicians learn to actually speak to their patients. So as far as risk of lymphedema, sure, anybody who has breast cancer surgery is at risk. Anybody who has radiation therapy in an area where lymphatics are located are at risk. Anyone who has an injury to areas where lymphatics live are at risk for lymphedema. People can develop swelling conditions for many different reasons. I do have a slideshow. However, unfortunately, right before we started this, a transformer blew outside my office. So I'm sort of winging it. So bear with me. How long does it take to develop lymphedema after you've had damage to the lymphatics? The answer really stinks. You can develop lymphedema at any point in time. According to most researchers, within the first 2 years is the most common. However, I've had patients 30 years post-op who fell into a pole on a bus and ended up with lymphedema in their extremity. It's very easy to disrupt the lymphatics, which is actually pretty upsetting in general, given that most individuals, particularly with breast cancer, never had medical complications. They had breast cancer, you think that that's the worst of it, and then you develop this chronic condition. And it feels like it's just the gift that keeps on giving. It's not really a gift. However, there are many different ways to treat lymphedema. Generally, people use complete decongestive therapy. Because you guys are really familiar with lymphedema, I'm not going to go into every aspect of complete decongestive therapy. I'm pretty sure that I would sound like I was preaching to the choir. If anybody wants really good information on complete decongestive therapy, maybe can we email the attendees the presentation maybe? So, okay. So
Absolutely.
hopefully
Absolutely.
we'll get you guys an email of the presentation because I did do a slideshow, and that way you have a copy of the website so that you could look things up. I didn't want to go into every single aspect because of the familiarity, but I did want to go into the difference between treating lymphedema and treating a human. I treat a person. My overall philosophy of care is to assist people in living with lymphedema and not for it. To me, that's my whole way of practice. The fact of the matter is, if anybody ever told me that I had to do something 24 hours a day, 7 days a week for the rest of my life, I would walk away and I would never do it. I know myself very well. I don't pay attention to my medical issues, and usually that actually gets me into trouble, so I'm thrilled that everybody's here. But it's not about completing every component of complete decongestive therapy. It's about me being a clinician and working with an individual. So I don't treat the condition, I treat the person. It's important as a clinician, in my opinion, to listen to what each patient says regarding their care, their tolerance to being wrapped. Kay's having a problem with her connection. Their tolerance for being wrapped, the amount of time that they can actually be wrapped, and whether or not that's even a component of their care. Nothing in this world is ever black and white. Lymphedema care is not excluded from that. Lymphedema care should exist in the gray area. Does the certification work? Sure. It came out years and years ago, and nobody has ever restudied how to treat lymphedema. But remember, when lymphedema first came about and when there were clinicians focusing on this problem, they were focusing on the problem, not thinking about function, because generally a woman's role in this world was deemed that they could be wrapped in a cone-shaped arm and not have that affect their function because they would no longer have to do something. It's 2020. We no longer have the option of doing nothing. The fact is even if we're stay-at-home parents, we have about 1 million things to do every day. And it's very, very difficult for people to manage in the way in which the certification says that you should manage. But a certification to me is a guide. I was a clinician prior to being a lymphedema therapist. So what I try to do in my work is remember that. So when I meet someone, it's not that I'm meeting someone just to treat their lymphedema. I'm meeting someone because I want to help make your life better. I want to help control the swelling. I want to help you be able to function in a way that you aren't limited because of your swelling. That means that I bend the rules a ton. Do all therapists bend the rules? No, but I think that a lot of times, if, say, you guys listen to this lecture and you hear some things that I say and it sort of brings something to mind, that is definitely something that you should go to your clinician and have a conversation with. Because even though I say it, it doesn't mean that it's true. No two people are exactly the same. So we have to make sure that we're really listening to lifestyle issues, because not everybody can respond to therapy in the same way. I could do the same thing to everybody, or I could truly evaluate the human in front of me, and I prefer the latter. So I believe that it's important to use my training as a guide, but not as a finite set of rules. I'm pretty bad at rules in all of my life. So if we look at CYNTHIA SHECHTER across the board, somebody gives me a rule, I will go the other way. I am probably the worst at being a patient, but I think that it actually makes me a better clinician in a way. So I change things, whether or not I use a compression pump, whether or not I use foam and bandaging, whether or not my patients are wearing sleeves and gloves all the time, whether or not people are wrapping themselves every night or using a nighttime garment every single day. Everything varies. I like having variables. I find that by looking at a person, I am actually helping people to feel more control of their situation. I think that particularly with lymphedema, there's a tendency for nerves to overcome actual. And I feel like the largest part of my job is that I need to educate patients so that, yes, do you have a chronic condition? Sure. But what can we do to manage it? What can you do? And if I sit down with someone and speak to them about exactly how much time they're able to devote a day, or whether or not they think that they have the ability to learn how to bandage themselves, or whether they need something that they pull on really fast because they're never going to do it. Those are all things that I need to know in order to help that individual. If I can do that, then I help individuals control their condition. And generally speaking, my patients feel like they're more in control. They have much less fear, and they're able to live their lives despite the fact that they have lymphedema. They're able to do the things that they want to do. They're able to get out there and function. That's what is important to me. Is it important to me that I do every single step of complete decongestive therapy? Not if it's not what somebody needs. The other thing that happens quite often, not sure how many people have actually had breast cancer, but with breast cancer, it's also important that you get rehabilitation. Generally, when I went, I was certified through 3 different schools. I went to the Academy of Lymphatic Studies, the CLOS training, and I also learned from a woman, Linda Miller, who was considered a pioneer and an outlier to the lymphedema community, because 20 years ago, she recommended exercise after breast cancer surgery. And it was pretty much rejected by the people who are really supposed to be trying to find a cure, but it was rejected, I personally believe, out of fear. Because if we tell people to start a strengthening regimen, are we putting ourselves at risk for liability? And I don't really think like that as a clinician. I'm very rarely concerned about my liability. I am always concerned about the person standing in front of me. I've had a lot of people come to me from therapy after going to other clinicians, and people have said a lot of things. I've heard clinicians tell their patients they can never get on a plane again. And to some people, that's the end of the world, because their love of life is part travel. How could I look at someone whose life is traveling and tell them that they can never do that again because they have lymphedema, because they had surgery for breast cancer? It seems to me that if I give everybody a very finite set of rules, will their swelling be controlled? Sure. But will they be living the life that they deserve and want? No. They're going to be too nervous. So I try to educate people as much as possible. It's not about this 4-page list of things that you're not supposed to do. It's actually about what to do if, God forbid, something happens. So whereas you'll get lists from going online, you'll get lists of precautions. But really, can I tell you not to get a mosquito bite? I don't think so. I think that the mosquito's going to bite you whether I tell you it should or not. But what do you do if you get a bite? My patients know that there are a lot of different things to do. So, for example, I had someone come in yesterday. She had a huge mosquito bite on her arm. She was absolutely freaking out, thought she was going to get an infection. We used Cordaid. It brought down the inflammation. The redness went away. She had her session. She felt better. The only thing was I made her a little itchy because the increase in the circulation clearly caused the histamine reaction in the insect bite. So I applied more Cordaid. And when I wrapped her, I said, honestly, if it gets too itchy, please take it off. But don't scratch that mosquito bite. If you get a paper cut, we have people actually give out a paper that says don't get paper cut. Okay, I mean, I get paper cuts all the time. I reach into a drawer, I get cut by a folder. The fact is there are things to do. I had a patient who was a hairdresser. She was told by 3 different therapists that she had to change careers because as she drew the hair down and went to cut, she would always cut into her fingers and she would have a lot of different lacerations. She was told she can't cut hair anymore because you can't risk having cuts on your hands because you have lymphedema. And when she cut herself, she was developing cellulitis infection. She met me. And what I said to her was, well, what do you do when you cut yourself? And she wasn't really doing much of anything. So I said, well, do you think that you could stop and wash your hands with soap and water? Sure. Okay. Can you apply pressure until it stops bleeding? Of course. Okay. So that's 2 things you're going to do. Do you know what new skin is? Liquid Band-Aid. If you get yourself liquid Band-Aid, the cut stops bleeding, you put on the liquid Band-Aid, let it dry, and go back to work. That way, not only did you apply something that is an anti-infection agent, but it also seals that cut, so no bacteria gets in there. And I ran into her at the store. She has not had to wear a glove or a sleeve. She has not been in for therapy. She has not had swelling in her hands since I taught her what to do if she cuts herself. Now, to me, it didn't seem like I did that much for her because all that I did was tell her to use new skin. But to her, that was a life-changing remark. She is at work. She's going to send her kids to college next year. She knows that she is able to pay for it. She is on the right track. And she didn't have to give up the career that she loves because she has lymphedema. And I don't think anybody should have to give up their lives because they have a swelling condition. I think we have to figure out what to do with the swelling condition so that you could live your life. And following a certification doesn't necessarily allow us the capacity to do so. The other thing is there's a lot of things on the market now that never existed before. We also know that muscle movement moves fluid. So when we wrap you and we make your arm into a big cone with lots and lots of foam, in what way are we creating a muscle pump? Wouldn't it be better if we wrapped a little bit smaller, perhaps, and then we actually exercise so that we can get those muscles moving, so that we could get the fluid moving, so that we could break up some of the protein molecules that are stuck in the extremity and the bacteria in there, because the lymphatics are, in fact, a filtration system. So they filter out the impurities that are left in our body. If they're not being filtered appropriately or adequately, then you end up with a problem. When I look at a patient, I'm not just looking at swelling. I'm looking at actually tissue texture. It changes the amount of pressure that I would use for my manual therapy. There are people that I would use a vasopneumatic pump. There are people that I would never put on the pump. The fact is, though, the pump has been demonized in the lymphedema industry. I agree that you can't use the pump as a standalone therapy. Most devices, other than the FlexiTouch, were developed to stimulate the venous system to work better. So that's your veins. Your veins are responsible for 90% of fluid reuptake in the body. Your lymphatics are responsible for the additional 10%, and they break down large protein molecules into small ones so that bacteria and things can filter through your body. So why would it seem that if you stimulate the lymphatics, you shouldn't stimulate the veins? The pump works in a very different way than the manual therapy, than the wrapping, than anything. But if I use the pump, quite often I use it to begin a session so that the tissue is actually a bit softer, so that when I'm working on someone, I can really get that fluid moving. What I'm going to speak to arm swelling briefly. I know that we really want to talk about breast, trunk, and abdomen. So, but with arm swelling, not everybody responds to wearing a sleeve all the time well. Some people end up maintaining their swelling, and I'm not sure that's what we want to do. I think a lot of times we actually want to get that reduction. We want to get that muscle pump. An elastic sleeve can help to control fluid from coming down the extremity. But generally speaking, I don't know how many people see a reduction in swelling because they used a sleeve. I think that the sleeve is maintenance. Unfortunately, the one thing that does happen with the sleeve is sometimes you end up with an area, particularly around the elbow, the ulnar ridge, where every time you go to lean, you have a dent. You have a dent because you have protein and other things backed up in your system, and that's pitting. When you have pitting edema in your arm, you put on a sleeve, you're not breaking up the pitting edema. The only thing that could really break that up is using a vasopneumatic pump, having a therapist use a different type of pressure with their hands, and wrapping differently. So there are all sorts of things that we can sort of modify depending on what an individual is capable of. You're smiling a lot. So let's talk about breast and trunk swelling. Breast lymphedema.
I'm smiling because it sounds familiar.
I'm thrilled. Yay.
I'll just let you go on.
I'm trying to cover all my bases, you know? So yeah. With breast lymphedema, what you'll end up seeing, so typically breast lymphedema happens after you have radiation to your breast, right? I mean, can people get breast lymphedema if there's damage to the lymphatics? Sure. Sometimes there's a genetic abnormality, there's a trauma, there are things that can happen. Typically, it's after cancer surgery or radiation, but certainly not limited to the breast, but it can occur. We can get lymphedema in the breast, we can get lymphedema in the chest wall, we can get lymphedema in the arm. All swelling will impact what we do and what a person does moving forward. So there are a lot of garments on the market for breast swelling and trunk swelling. Unfortunately, most of them are horrifically uncomfortable. Most people feel like they're in a corset. They feel like it doesn't fit. They can't sit. They have to undo it to sit down to drive in the car. They absolutely despise their garments. It's sort of like if we were really heavy in the olden days and we had to get into one of those dresses that has a waist that's a size 2, they just used a corset. There's not much of a difference. The abdominal and breast garments that are made can be very rigid for people. If it's uncomfortable, most patients aren't going to use it. So what can people use? And I really think it's important that we look at things that are not just for the lymphedema community, because there's plenty of garments on the market that could work. There are high-cut sports bras that fit very tight. If it's high-cut enough and it comes up into this area, then you're really giving yourself the compression that you need. Is it a 30 to 40 millimeter of compression garment? No. But are you going to be able to walk around for an entire day wearing a 30 to 40 compression garment across your chest wall? Probably not, because it's going to be nearly impossible to take a deep breath. And those are the things that we have to look at too as clinicians. We can't just make blanket recommendations and not listen when our patients come back and say that that is not an option for them. We have to figure something else out. We as clinicians need to be more flexible and creative in our therapy. If there's progress in every type of medicine. For example, the first total knee replacement was a metal replacement. It always had to be replaced. Everybody went off in the metal detector. Now they use titanium. That's a difference. every area of medicine has shown progress based on years. But nobody has really written anything up that has changed the way in which lymphedema therapy is provided. And sometimes I think that that's where there's the glitch, that we are teaching based off a certification that is from years and years ago, and we are expecting for people to change their lives completely based on a condition. And that's not fair. People shouldn't have to change their lives based on a condition. The condition should be treated differently so that it fits within a lifestyle. And I think if we could change the way in which people think about lymphedema and sort of stop the wheel of, just regurgitating the certification, we might be able to take this further. We might be able to help people become significantly more functional, significantly more independent, and significantly more comfortable. One of the things that we're taught when it comes to breast cancer is that we should work around the radiated tissue and the scarred tissue. I'm an occupational therapist. I was taught manual therapy for scar tissue, for any tissue that is stuck. Now, if somebody's tissue is stuck in their chest wall or in their armpit, in what way are we going to get that fluid to move? It's almost like there's a blockade in that upper quadrant. But if we can break up that scar tissue and we could get that you really moving, that's when you'll feel better. When you can raise your arms over your head without feeling a horrific pull, that's something that you need for your life. After breast cancer surgery, a lot of people think that they're supposed to feel some sort of discomfort, and it's okay to be uncomfortable forever. But it is not okay. There's no reason for people to have to walk around uncomfortable. If clinicians take it back a moment and really get things going and start thinking about what it is that they're looking at. When I look at an adhered scar to a chest wall, I know that I'm really not going to get much reduction until I get that tissue moving. Once that tissue is moving, not only am I able to get a nice reduction of swelling, but I'm also able to then work with someone to really get rid of their swelling. Sometimes you can break up all that scar tissue and an individual swelling actually goes away because I opened up the channel. So then the question is that lymphedema permanent, or is there something that we're missing? If we catch it within the first few months of having it, it is reversible. If we could work on getting tissue moving, then can't we get the fluid moving? So it all comes back to looking at the individual sitting in front of you. If somebody has a 30-year-old scar, I still work on it.
That's a great point to stop. We're at the, as far as going back, it goes back to the individual treatment. We're at the half hour. We're 30 minutes into the hour. So if you want to open, we've only got 6. No apologies. We've only got 6 participants. So I think this is a great time to open up for Q&A to allow them to ask their questions, see what kind of dialogue we can kick off. So if anyone has any questions for ShechterCare, Cynthia, our esteemed guest here, by all means, go ahead. Kay says, I'm always looking for alternatives for compression of the breast and trunk that are affordable, easier to don and off so they can be worn. So are people able to use audio to speak up, or is it just chat? I just want to make sure that anyone who actually wants to use audio has the ability to do so if they want to.
So as far as garments for breast swelling. Oh, that was a good question. I'm excited about that one. Anyway, for manage, now I lost the question. The question was different items for compression of the breast. So the most common thing that people use is the Belize compression bra. I've tried it on. I find it very difficult to tolerate. I generally don't like to be made uncomfortable by anything that I'm using to make myself better. What I find that actually work the best are high-cut camisole tops that are like those slimming tops so that they have the elasticity. Those work well, and honestly, a good supportive sports bra can be great. The only problem is you can't wear something that's very, you can see me, right?
Yeah.
Me? Okay, so you can't wear a tank that is this low, because then you'll just have a lot of swelling that comes up higher. But if you can get yourself a sports bra that actually cuts very high up close to the axilla, you actually will have plenty of compression. The other thing is that, you know, with the breast swelling, you also have probably scar tissue from the surgery itself. If you can actually massage that scar and get it moving, then you may find that your breast is less swollen because it has less inflammation. Our body responds in an inflammatory fashion, no matter what. So if we have an infection, we know that we get increased swelling. If we have a surgery, a lot of people are afraid to have, you know, the general, say, CIMT arthritis, the joint replacement in the thumb, the carpal tunnel release, trigger finger release. People, a lot of times, actually, the aromatase inhibitors, a medication that women who are postmenopausal take for their breast cancer, if they're hormone positive, actually cause a problem with trigger finger. It causes soft tissue issues. So then people have trigger finger and they think that they have to live with it, but they don't. It's a matter of making sure that we're getting everything covered. But the slimming tops work great. Actually, I had a patient go to Target. They sell almost all of them. And as long as you get the high cut on the underarm, it should help you control. And then maybe you won't feel like you're wearing a corset. What was the next? Do we have any more?
I've also used the Maiden Form Flexi.
Yeah.
It's about $25 on Amazon.
For abdominal swelling, those things work too. Like there are actually, if you put on a pair of bicycle shorts, it can help with abdominal swelling. They sell items that are for abdominal swelling, but to me, a lot of times when people sit down with that garment on, it rolls up and it becomes like a corset or like a rope. And that's the last thing we want to do. So we have to find things that actually fit well. I think there's a lot of over-the-counter non-medical garments that will work well for people. And it'll help you feel so much better and more mainstream so that you don't feel different. And you're not wearing some badge like that you have a swelling problem.
Sorry, Cynthia, can I come back to your question regarding the scar tissue, about massaging it? Do you have any special techniques? Is there something you have to be aware of? You know, also not to overdo it, perhaps, not to make it inflamed. And can you start, I mean, from right after your treatment, or, you know, when is it? I mean, I suppose it's better to start right away, or is there some kind of process to do this?
So it's interesting that you asked that. I just moved my practice from Manhattan to New Jersey. Doctors are very, very different. In Manhattan, everybody came to me probably within 14 days of having their surgery, and I would start working on them. Now, did I work on their surgical sites? That would depend. If people have a lot of scabbing, or if there is if there are wound healing issues, then certainly I have to work within the confines of that. But even if somebody has a wound healing issue, say their wound comes across like this piece of paper here, their wound is at that X. Can you see it? So if I were working this, instead of spreading the surgical site apart, I could actually take my fingers, put them around the scar, and work in a circular motion, keeping that scar together. When I do it that way you're working on it and it's not as scary. What I find is that if I work on the scar tissue early, patients are so much more comfortable and they don't develop quite as much of a range of motion issue. When they have the range of motion issues, then that just lends to developing a swelling condition. So that's the other thing. There are a lot of facilities that will treat lymphedema before they'll treat range of motion. And I think we should treat both at the same time. To me, just treating someone for a swelling condition, you really can't make any recommendations if you haven't started working on the scar in the range. So at my clinic, I work on everything at the same time, meaning that I will do manual lymphatic drainage, I will get things moving, I will pay attention to the fact that somebody has swelling, but I'm also going to look at their whole chest wall. I'm going to work their surgical sites. If somebody is far out from surgery, I'll work in a much more transfriction sort of way where I'm actually trying to spread the scar apart. But initially, certainly, you can't do that, right? It would be bad. But you can teach patients to do some self-scar massage. You can show them, and you can explain that, you know, until all of your scabbing is gone, don't do this. But once everything is closed, it's time to scar massage. Then the patient is also vested in making themselves better. So instead of just giving a wall walk, which personally I hate that exercise, I find that most people cheat. So you get to this point and then you start to sort of bend your body and you go and say, look how much higher I am. And then you stand up straight. And really, you're not very high at all. You're in the same exact spot. I mean, I could leave the tape on the wall. So I actually like slides better because you don't have an option but to allow it to stretch you. It is really scary for patients and some clinicians to work on a new scar, even to work on a new drain site where somebody just had their drain removed. It can be frightening because we don't want to cause an infection. We don't want to ruin the wound. We don't want to mess up someone's surgery. The fact is we're not as capable as we think we are of causing damage. And sometimes we just have to wing it and use just whatever we think is right as a clinician and not listen to everybody telling us everything to avoid because it becomes way too difficult. But if we could get people moving, when people have a lot of tightness in their chest wall, when they don't come for therapy for, say, the first 3 months, and the surgical site heals and they're kind of stuck, they don't get the assistance of their diaphragm, their abdominal muscles, their thoracic duct, which are all drainage points for lymphatic fluid. You can't take a deep breath when you have too much scar tissue in your chest. Your lungs don't allow it. You can't expand. After radiation, the lung clearly is partially at least damaged. When that is damaged, of course, it's going to affect your entire core. So if we can loosen it earlier, then we've already restored all of those abdominal supplemental lymphatics to help. So the radiated tissue is different, clearly. If somebody is very red and has a lot of peeling or blistering, I don't work on that tissue very much. I'll work on the tissue below it. I'll work a little bit on the range of motion. I'll do mostly drainage for comfort. But once that skin heals, all bets are off and I'm working on that tissue. I'm working on any scar adhesion that's in there. Yesterday, actually, I saw a patient who I've been seeing via telemed because she had to start radiation and she had about 5 degrees of range of motion in her shoulder. Surprisingly, she was really able to restore her range. Oh my God, the lights. Sorry, I got really excited. The transformer is no longer. It's because I already did the
Let
presentation
there be
part,
light.
and I can't show my slides. I'm so sorry. That's hilarious. And I'm like, it's not cold out. So they start really understand the warm. Oh, God. Okay, anyway, so if we could work to prevent the issues from occurring, we could actually help people prevent getting lymphedema. There's so many different ways to manage every single issue that we have in our body, right? Why do people go for second and third opinions when they're diagnosed with something? Because everybody has a different one. The fact is I think that it's time that we lymphedema therapists start having different ideas, because the basic way of treating lymphedema is limited. Do we help people get better if we treat that way? Sure, but what did we put them through to get them there? And are they able to continue to manage their swelling independently if we treated them in that specific fashion? So,
Cynthia, with respect to breaking up the scar tissue, we had the conversation last week, and I was telling you that while I had never been a breast cancer patient myself, you know, I've had, I don't know how many surgeries that have gone through my belly button,
right.
Laparoscopic wise, because, you know, I've had just at least 5, you know, off the top of my head, that have gone through my belly button. And you showed me the little cup. Would you speak to the cup for breaking up that scar tissue?
So this little wonderful cup that VP is referring to is actually made, if you could believe it, for people to use to suck their cellulite out of their bottom. So if you know anybody who would like to do that, I certainly don't, but you can use this cup. Oh my God, these emails. Okay. So what I use this cup for is for getting rid of adhesion, like what VT is talking about. She had lots of laparoscopic surgery to her abdomen. These cups cost like $8 on Amazon. They're actually called Cellulite Cups. I can't believe they exist. I am still in shock, and I've been using them for 3 years. That said, they work really well for things like the drain site area where most people get an adhesion, and any scope, because when a doctor is doing something where they're inserting something, they actually don't cut a large hole. They cut a little, and then they feed a tube through, and it actually causes the skin to heal in an internal fashion. So your skin will sort of stick in. And I bet you if we had 10 people standing in front of me and everybody had breast cancer surgery, whoever had drains, they all have those little adhesions. You take this cup and you put it on the tissue itself and you squeeze it and you let go. It's similar to cupping in that it is pulling the tissue itself away. But what it actually does for those drain sites and those adhered laparoscopic surgery sites is it sucks that scar out and it gets it unstuck. And being unstuck feels phenomenal. It's such a different thing. You no longer, when you go to raise your arms, you no longer feel that terrible pull from that site because you were able to get it moving. Now, if it's on your abdomen, then we could also do lots of abdominal stretches to get those adhesions to loosen up as well. So if you do the cup and then you do the stretches, you could probably release your own adhesion. You could also go to a clinician and say, I can't stand the way that it feels when I move. And somebody can work on that for you. So I guess in my talk, this talk, what I really wanted to get across is that if something isn't working for you, there's a reason. If it doesn't feel right, it's not right. If your wrapping is uncomfortable and causing you pain, then something's wrong with it. It doesn't mean leave it on and take some Advil. To me, I would prefer for you to take it off, because if you feel like something is rubbing, then it is probably rubbing. If you get a sore because something is rubbing, then you're predisposing yourself for an infection. But having the awareness that it's okay to take it off. Your arm's not going to fall off, but the fact is you should not be getting skin lesions, irritations, cuts, blisters, anything from anything that a clinician does to you. And if you do, it doesn't mean that you're seeing a lousy clinician. It means that you have to go back and communicate, because we quite often do what we think is right, but that doesn't mean that it worked. And that's what's important. Is what we're doing working? And if it isn't working, what can we do? Because that, in the end, is the A1 most important thing. We have to help people get back to their lives. If somebody was a mountain climber, they should be mountain climbing. There's no reason that somebody who had breast cancer surgery or somebody who's at risk for lymphedema, there's no reason that they can't mountain climb. It's a matter of making sure that you have the strength, that you have the appropriate precautions, that you know things to look for, that, you know, I mean, it could be something as simple as if somebody likes to free climb on a rock wall, you know, maybe wear gloves, see if you can avoid cuts. But it's not all about me telling people what they're not allowed to do anymore. I think it's important that we actually look at someone and say, what is it that I can do so that everything that you want to do can be done? Oh my God. I had about 18 messages just now.
Oh, you have 18 messages? Okay.
No, it was all that the power was restored.
Oh, okay. We have
Julie.
We have Julie Waller with her hand up. I don't know if Julie, did you want to speak and say something, or? Her hand went down. Okay.
I think there was a question about post-op exercises.
Okay.
If there are any recommendations or suggestions for that?
I do. So like I said before, I really like the wall slides. And I try to get all of my patients first visit to get the pulley. So I do that because I want people to start moving. The pulley is a nice way to start because they are controlling their own movement. I make sure that I teach not to bend and that it's okay if all that you get is this much range of motion. I do try to get patients to straighten their elbows as they're coming up because there is a lot of cording or axillary web that happens post-op. But what else do we do? I use the upper extremity ergometer, the arm bike. I particularly like when I wrap someone and then I have them go into the gym in the back. I actually use the TRX straps, I use TheraBand, I use the foam roller. The foam roller is a great stretch. And actually one of the first things that I do is I might have a patient who has so little range of motion or who's so guarded because they're so afraid to move. I have them lay on the half foam roller and let their arms fall to their sides and work on deep breathing with their knees bent. And that way they can start to feel that their shoulders can actually drop, and it doesn't mean that they're going to rip open their surgical site. Sometimes I have patients get a foam roller. Some people take a blanket and roll it at home and use it just so that they could get that little bit of stretch. I may have someone do partial angel, where you only come maybe 80 degrees of motion, because they'll start to feel that they have control over what they could do. The last thing that I want is to put too much pressure on the surgical site, cause pain, and then sort of reverse the ability to do so. So I do take it slow. I usually like to restore range of motion prior to doing strengthening, but my patients do strengthening. I do weights with them. My goal is, so I just generally assume that everybody's going to have a fall at some point in their life. I find that it's easier to just think like that. everybody's going to fall, everybody's going to put out their hand. You have 20 people who have had breast cancer, who had axillary node dissections, maybe 6 of them get lymphedema if they fall on an outstretched arm and 4 don't. Usually I think the problem is that they don't have enough strength to support their weight. So when a doctor looks at a patient and says, you can never lift more than 5 pounds, I think that they forgot that we push up from chairs, and that's more than 5 pounds. We trip and we catch ourselves, and that's our full body weight. So if we're not working on getting them stronger, then we're predisposing people to an issue. So I do like to do a lot of strengthening, but initially I will do a lot of stretch. A lot of my patients like to do their wall slides in the shower. I don't really care where someone does it. As long as you do it. I think that opening up the chest wall and giving people sort of sensation that they can stand up straight is so important. So most of what I do is help people develop an awareness of their position in space, help people understand where their body is and what needs to move, and sometimes putting them in positions where they feel that pull opens up the opportunity for them to clearly understand why it is they're doing what they're doing. And when you clarify why they're doing what they're doing, then you're really able to be of assistance because they feel it. So
yeah, this is giving me some ideas for we have a group called the Lymphie Strong Running and Fitness Club, and Pernilla, she's always doing research there too to post different exercises. And there are these sliders that you can put on your hands for you to do floor work. Almost like
they're the same things as the foot ones that you're supposed to
slide. But you could use theoretically you could use your hands to be in a yoga pose and then go out, right? Instead of trying to go into the wall. And I actually did that. And it's pretty hard. It's like that ab roller that you can get for like $8 at a sporting goods store. And when you roll out on your to do abs,
are you talking about the wheel?
Really tough. Yeah.
So I actually tried to take my son's sliding things and put them on my hands to see what I could do for exercise with patients, and I lost it, and I fell flat in the basement. I was like, uh-oh, this is really hard. It is.
It's harder than it looks. Yeah,
I was not really mentally prepared. I wanted to do the slide and leg lift, and then the slide I fell flat on my face. So, but can somebody who has never done strengthening after breast cancer surgery do that? No. But can we get them strong enough to be able to? 150%. And I think that's sort of the take home. What can we do to get everybody better, as opposed to just how do we implement this certification? We have to look at people. People are what matters. I think if anything that we're learning from the disasters that are going on in this world right now, people matter. And as a clinician, I know my job is to make my patients' lives better. And in order to do so, I have to work as a partner as opposed to a boss. And it's just a different way of looking at care, but I can't imagine being anything but a partner. And I think we could do better, and I want to do better.
That's amazing. Do we have any other questions from the participants? We're right at the top of the hour, but I know you said you were willing to go over if needed or if necessary.
I'm good with anything. No one?
Okay, well, I'm going to ask another question that I don't know. Oh, Kay has one. Kay lifted her hand. Okay. Julie stole my question. Let's see. Well, Kay, okay, it was Kay and Julie, but Julie stole my question. Kay says, and Julie, we will get to you because Cynthia said she's willing to go to an hour and a half, 2 hours if necessary. Can you go over breast mobilization? What is breast mobilization?
Okay. Breast mobilization in terms of manual lymphatic drainage, breast mobilization in terms of scar.
Uh-oh.
Is that bad? I could do both.
No. She wasn't specific. She just said, can you go over breast mobilization?
Okay, so if I were treating somebody for scar tissue in the breast, I would treat it exactly the same way that I just showed. I would work with the scar. I would work against the scar as it's healed. A lot of times people get seromas, which is a fluid-filled sac that forms typically either near the surgical site or in the axilla. Those I will work on. I will also teach patients how to put pressure on those areas to sort of get the seroma to drain. As far as manual lymphatic drainage for the breast, it's not really much different than regular manual lymphatic drainage. I start at the neck. You do the terminus. You do the sides of the neck. I come around. I come back down. If somebody has unilateral swelling, I will work both down and across as long as there are no precautions. The first thing that I do is what every other therapist does. I open up all of the areas where we can have drainage. Generally, that's the first thing you have to do if you don't open up areas to receive. Exactly. So if you don't open up areas to receive the fluid, then you're sending it nowhere. So that's a problem. You're so good. That said, then when you work on the breast, it sort of depends on how the swelling is. So if somebody has what's called peau d'orange or orange peel skin, which means basically that you could see the hair follicles in the breast, that's someone who I'm going to work pretty firmly because that tissue has a lot of backed up protein molecules, bacteria. The lymphatics have just not been kind. Typically, it's after radiation. I'll drain across and down the same way. Do I work the whole breast? Yes. When I'm working it, am I always paying attention to what direction I'm going in? No, actually, because I know that if I'm going this way, I'm going to send it to this armpit, and if I'm going in a downward direction, I will be able to get to that fluid and drain it down to the groin. My pressure is different because the firmer the tissue, the firmer the touch. So if I have a patient who has tons and tons of peau d'orange, I will probably use a lot more pressure. I find that if I don't, all that I do is move the superficial fluid and actually the breast will just become harder. So it's a matter of making sure you know where the fluid's going to go and make sure it's ready to receive it, and then just working on softening the tissue. So I use a lot of what's this part of your hand called? I'm having a brain problem. It's the finger pad, though, not the palmer. Okay, so sorry. So you use the pad part where your fingers are. If you come in there, you can actually really get some good pressure. I keep my fingers pretty much still because it's not about taking my fingers and kneading into the tissue. That's just going to cause discomfort. What I want to do is really get that fluid moving so you're coming across. I always call it like it's either a forward C or a backward C. That's sort of the movement that I use when I'm going across, when I'm going down. Usually it's circular. But my pressure will change depending on what the tissue mandates. Does that answer it?
moving on to the next question. The next question was, my trunk, all lymphedema is creeping up from the opposite way. I have bilateral leg lymphedema. So this was very close to the question that I was going to ask. You know, we have so many members who say that they start out with lower extremity lymphedema, and after wearing the garments or being compliant for X amount of years or some period of time, they start to feel the swelling either creep up into the buttocks, or they feel swelling in the abdomen or pelvic region, or even the groin. Is that okay?
Is that what?
How would we treat that, or is that something that we need to go back to our clinician for?
I think both, actually. So abdominal leg swelling is difficult, right? We all know gravity wins. It's a terrible thing. I hate gravity. I wish I could eliminate it just for the purposes of lower extremity swelling, because it would change a lot of the rules. Lower extremity swelling as opposed to upper, you always have to get a compression, otherwise fluid goes down. I find the same thing, but I actually think that you can tell your clinician that you're having a backup of fluid in your abdomen, in your pelvis, in the labia, in your behind, and your therapist should be able to work on that area to reroute that fluid and get it out of the way. The fact is, these compression garments really just house fluid. Unfortunately, they stretch enough that they accommodate whatever changes your body has. Really, it's a matter of making sure that the fluid is being sent to the appropriate drainage site. So if you have terrible swelling and it's in your abdomen, from your abdomen down, then I really better work your neck. I better work both axillas. I better work up your sides, because I have to get all of that fluid out of that area. I can't really work on your legs until I get rid of all the fluid that's blocking, because then all that I'm doing is sending it higher, which, fine, it's higher up, but you're probably much more uncomfortable. So it's a matter of making sure that your therapist is working the anastomoses. Are they really working this area to bring the fluid upward? What are they doing when they're working on your abdomen? Are they sending the fluid out and then up, or are they just trying to go straight up? If your reaction to the therapy is that it's worse, then it's worse, and you should tell your clinician. Sometimes clinicians don't always notice. We're flawed as well. We might have seen 30 people between your two appointments and not recall what happened exactly in that session, although we should have it documented, but that's a separate issue altogether. But if we send the fluid out and then we work in an upward direction, then we're really getting to that fluid. Then when we work on the legs and you're sending the fluid to the outer thigh to go up to the anastomosis, we really shouldn't have that bottleneck in your abdomen anymore. Did that answer?
Gotcha. Yes, ma'am.
That was good. Okay.
Yep.
But I always say, if you're not happy or you feel that you're not getting something out of therapy that you should be, don't feel defeated. Lymphedema is something that a lot of us would end up feeling completely defeated, where we feel like we just have no control. People feel like they lose their lives because of a condition, and it's so unfortunate, because this condition is an insidious thing. It's terrible. I agree. But if we can change the way in which we teach our patients to live with it and not for it, then we've made a tremendous difference in someone's life. And that's so much more important to me than following the steps of what it is that somebody taught me in a classroom. I think that the difference is people. And if people can feel comfortable to speak to their clinician and to communicate what's going on, then we can help better. And if your clinician isn't listening, then that's a problem with not with you. If your clinician isn't listening to you, or your clinician isn't able to modify what they're doing based off the feedback that you're giving, and you don't feel like you're getting better, get another opinion if you can. It's hard to find lymphedema therapy to begin with. It's even more difficult to find clinicians who are willing to be creative with their lymphedema therapy. But if you can really control your situation. And I really think, if anything, I hope that I'm helping people feel that what you guys do and what you guys tell us is the most important part of being a patient. You have to communicate with us, and we have to listen to you. If we're not listening to you, you can find someone else. But people and clinicians should listen. There's a reason, don't worry about it. There's a reason that something doesn't feel right. And you know your body. If it doesn't feel right, it probably isn't right. And please make sure you communicate, because needless suffering is needless suffering. And people should feel better. And therapists should be better. We have to be better. We have to be better able to listen and work with individuals. And if we can, then we can really make a difference together.
Mm-hmm. We've got 2 more questions.
Ooh, nice.
And then we'll stop. We'll halt everything for today. The first one is, Pernilla, do you want to read it, or? It says, I was given a compression sleeve for my arm, and within a few days, I also developed breast lymphedema. Is this a coincidence, or could the arm sleeve have contributed to the breast swelling? Thanks. That's from Jessica.
Okay, Jessica, could it have contributed? Yes. Could it be that you had very mild swelling on that breast to start? Maybe. Generally, I'm assuming you're wearing the sleeve all day. Can that sort of cause a bottleneck in the chest wall? Sure. It depends on how tight that compression garment actually is, whether or not it's a good fit. A lot of times people have garments that the silicone band at the top is so tight that when they take it off, they have like red indents from the silicone band itself that could last for the whole day. That garment doesn't fit right. The garment can cause a backup, because what it's doing is basically what a tourniquet would do. It's stopping increased fluid from coming down the arm. So if you're stopping the fluid from coming down the arm and we're not telling the fluid where to go, the breast is a very easy spot for it to sit. Also the upper arm. Some people get it underneath their arm and then it comes into the top of the breast. That happens because there's an ill fit. Even when we get patients custom sleeves, custom garments, custom compression leg garments, they're measured, and then it takes 3 weeks to get it. Those 3 weeks, a lot of patients are actually discharged. So you go about life for 3 weeks where you're just waiting, and then your garment comes and it doesn't fit you right. And you don't know that it doesn't fit right because you've never had a garment. To me, these custom garments, a lot of them aren't necessary, because when we're measuring people, if they don't have a lot of deformity and it's just that their limb is larger, the off-the-shelf garments can help, and they don't end up rubbing in certain areas. So what happens, what I find a lot with custom garments is that people have real irritations in their elbow crease because the garment itself is very thick and uncomfortable. And when you're moving, it's rubbing. If you feel that rubbing, that's a problem. That's going to actually precipitate swelling. It's going, you'll probably have an increase because what you're wearing is actually irritating it. So can a sleeve cause other issues? Yes. Do I know whether or not your sleeve caused your breast swelling? No, only because I don't know you. If I knew you before, then I would be able to answer it maybe a little bit more clearly. The fact is anything can put you at risk for anything else, right? I know a lot of people who had breast cancer surgery and they were recommended to wear a compression sleeve for prevention. And they get on a plane with their sleeve and the plane lands and their hand is the size of Kingdom Come. And then they have lymphedema. So what did we do there? We stopped the system from working for the period of time that you were on a flight, and we didn't make sure to compress the distal extremity, which of course is where the fluid wants to go because it's gravity. So sorry.
Right.
Uh-oh.
Okay.
Sorry.
Final question. Uh-oh,
Okay.
lost you. Okay. Final question is, I have lipedema, Lipedema, and lymphedema. Do you treat both? And if so, do you treat them the same?
I don't treat any two people the same. Do I treat both? Yes. Is lipedema more difficult to treat than lymphedema? Yes, because it means that the tissue has turned to fatty tissue. But you can reduce swelling, whether it's lipedema and lymphedema, whether it's just lymphedema. You would think I was the most popular person in the world at this moment. No? Seriously. I'm just saying, like, I can't even, why is this, it's driving me bananas. And now I'm back on driving mode, just so you know.
This is the last one, and then we're done. One and done, one and done.
The difference is that with lipedema, you actually don't use a lot of pressure because you don't have as much protein backed up in the limb, generally speaking. So what would change is more the pressure in my hands than anything else. But usually I let the tissue sort of lead me. I feel what the tissue is, and then I really hate to say it, but my hands kind of know what to do from there. So I almost feel like my hands are the clinician and I'm really just a puppet. For some reason, I can feel the tissue. If you need a lot of pressure in an area, then I'll use it. But if there's an area that is really, really soft, all that I need to do is get that fluid to move. So I don't need to press hard. So, and then the wrapping technique, is it the same? Sure, but my wrapping technique is probably different than a lot of wrapping techniques that you've seen because I try to keep it as small as possible because I want you to move. Sometimes with leg swelling in particular, whether it's lipedema, lymphedema, or both, a lot of times I will start by just wrapping to the knee. That's not because I don't think that the thigh needs compression. It's because a lot of times the lymphatic swelling is more distal, meaning lower down on the limb, and the lipedema is a little bit more proximal, like in the thigh. If that's the case, then that tissue I could really get moving. If I stimulate that tissue to move enough and I wrap you to the knee, then generally speaking, you're more functional because you don't feel as stuck. But the treatment is generally the same. Do I want to say that it's exactly the same? No, but I probably wouldn't even treat both of your legs exactly the same. because each one has its own way. Does that make sense?
Yes, ma'am.
Oh, is anyone there because I can't see?
Echo, echo, echo.
Oh, God.
Janet didn't respond yet, but I think that's all we have for today. We're at an hour and a half, and I know it's getting late in Europe. It's raining cats and dogs here, so I'm not quite sure how. Janet said thank you.
You're welcome.
She's a really, she's been a member of Lymphie Strong for a real long time. Really great lady.
Yeah.
That's
awesome.
So I think I'm treading water here with this thunderstorm. I want to thank Pernilla for staying so late and joining us from Europe. I want to thank Cynthia for allowing us to pick her brain and for answering our questions and being with us here today. I know that you're pretty much, an open book, and you're willing and ready and willing to help anyone, really. I saw you give out your personal phone or your phone number on the thread the other day.
Oh, yeah, I always do.
So,
actually, I'm in touch with people. I'm going to get her what she needs.
So I know, when members have questions from time to time, you jump in when you can and you help. So we're really thankful for people like you, clinicians like yourself that are able to help us in the patient support community. Pernilla, did you want to say anything?
Yeah, I just want to say thank you very much. It was some great insights. Obviously, I'm a primary lymphedema patient, just like Veronica, and sometimes it's I try to steer away from not giving any advice or suggestions to breast cancer patients or with lymphedema, because I don't have any personal experience. So this is great for me to also have a bit of more of the, not the scientific part, but also more from the clinician side of it, and that's really helpful. I think for us, I'm sure also you, Veronica, it's nice for us to have this kind of insights as well from a different point of view for other patients.
You guys if you ever have additional questions or you're stumped with a patient or anything, please feel free to reach out. I'm an odd person who just wants to help everybody. So use me, because I'm pretty passionate about helping.
Okay.
That's all I want.
Thank you so much. Thank you, everyone, for joining us. Okay.
Thank you so much.
Bye-bye.
Bye.
See you.